Hello, welcome back. This is Module 2, Lecture 1. Module 2 is in a one-week module. The lecture is Foundational Frameworks of Quality Improvement. And we're going to start with, it's probably going to end up being 3 8-minute chunks. Start with the fact that for the past few weeks we have discussed the idea of quality. We've never really gone into a detailed definition of what quality is. Now, this was kind of an exposure to the reality that many health administrators face. A lot of them go through their whole careers without really having a definition of quality. And instead, they just kind of assume that they'll know it when they see it, or they'll feel its absence when it's not there. Unfortunately, that doesn't do a whole lot for improving quality. In order to really improve something, you have to know what it is, and then you have to be able to measure it well. Once you've done that, then you can go about the business of identifying the gaps and filling them. Unfortunately, even for the leaders of the field, quality is very hard to define. Of course, you can find a definition in the dictionary. Merriam-Webster says that quality is a peculiar and essential character. That's nice, but it's not terribly useful. The International Organization for Standardization says that to determine the quality of something, compare it to a set of standards, making it inherently relative. This is getting better, it really is. In fact, the ISO 9000 produces the standards for quality measurement used in many industries, including healthcare. However, their rote definition is a little too nebulous as a standalone. Even the father of quality, in whom we're going to spend a great deal of time discussing, Avidis Donavedian, had a very hard time defining quality. In his seminal article, which came out in 1966, he said the assessment of quality must rest on a conceptual and operationalized definition of what the quality of medical care means. So he was focused on medical care. He's an MD and MPH. Many problems are present in this fundamental level of quality of care, and it's a remarkably difficult notion to define. He added the definition of quality must be almost anything anyone wishes it to be, although it is ordinarily a reflection of values and goals current in the medical care system and in the larger society of which it is part. We're getting there. It's a much better definition, and he ultimately does a great job of defining quality, as you'll see. The Institute of Medicine report, Crossing the Quality Chasm, actually uses Donavedian's definitional assessment of structure, process, and outcome in defining quality. And it's in that order, and you'll understand soon why. By the way, I did not assign you the Donavedian papers to read. I highly recommend that you read Evaluating the Quality of Medical Care and the Quality of Care, How Can It Be Assessed? Both of these will be posted in the online classroom. You are not responsible for them for this class. I've linked them just because I think everybody ought to read them at some point in their careers. Your responsibility is limited to the contents of this lecture or anything else mentioned about Donavedian in any of the assigned readings. The seminal work from 1966, which I quoted earlier, discusses structure, process, and outcome in medical care as the core essentials of quality. Structure denotes the personnel, the facilities, and the equipment involved in the provision of care. This includes the qualifications of the providers and staff, the condition and efficiency of the building and its layout, and the adequacy of the equipment, including its contemporaneity, availability, and usability. I couldn't find another word that says contemporaneous, whatever. Process denotes the actual delivery of care and its recording. This includes all aspects of care, including the consumer's making of appointments, arrival at the care facility, the waiting period, care delivery processes, and follow-up. As can readily be assumed, the structure contributes considerably to the process. A well-trained nurse working in an area of expertise who remains current in the latest procedures and the best evidence and using contemporary equipment that is readily available and in good repair is more likely to provide excellent care processes. Additionally, Donabedian properly stated that the measurement of the correlations between structure and process is complex and ambiguous. It's quite possible that that same nurse in that same situation could give poor care. And this could be because of poor information, poor communication, unexpected interruptions, an infinite number of reasons. Now, outcome denotes the morbidity and the mortality. More specifically, good outcomes include recovery from illness, restoration or improvement of function, survival, improvement in or satisfactory ability to manage pain, or a dignified death. I worked in hospice. A dignified death is a very positive, high-quality outcome. In many ways, outcome is the ultimate criterion for measuring quality. It is reasonably easy to measure outcome in its simplest terms. Morbidity and mortality are concrete by nature. Their measurements are relatively stable. They're valid across places, times, cultures. Unfortunately, in the absence of structure and process, outcome is limited and sometimes irrelevant as a metric for quality. Consider this. You have a person who recently underwent an open reduction of a compound fracture. It was completed in a poorly lit, poorly supplied operating theater after having waited for, say 2 hours in the ER waiting area without having any analgesia. Okay? Quality assessment based solely on the outcome might find that he had a quality result. The surgeon ultimately restored the function and managed the pain. However, a quality manager looking at the process, the structure and the process of care in addition to the outcome would rate the quality of his care insufficient or poor because of the inadequacy of the facility and the care and the equipment and the extended wait and the inadequate pain control during the wait. That would be the structure and the process. So what does it mean to us? Well, it means that quality managers can only measure quality in context. Quality managers need a combination of historical information, standardized measures of quality, sources for comparative information. Additionally, a quality manager needs an understanding of the structures, processes, and outcomes consistent with quality. In a later paper, this is the one from 1988 that is also available, Donabedian added that the healthcare consumer and his or her engagement in and willingness to abide by the recommendations and prescriptions, which would include healthy lifestyle, following medication dietary regimens, exercise, all of these add to the aforementioned structures, processes, and outcomes in assessing quality. I'll be back with another edition.